I'm happy to answer any questions from the audience. Okay, first about the staging. We did have 92% stage 3 and 4 disease, but your series is a pathological staging. And if our patients had surgery, that may have even been higher. The patient who had an EPP had, on the PET scan before surgery, disease which was clinically T1N0, but after he had his surgery it was T3N2. And there's this stage migration that you need to consider as well. Now, the second question, sorry, was about...
well, you showed some nice pictures of the pre-radiation PET scan
yes.
showing FDG activity. But many of those patients would have had surgery prior to that. How do we know that you're treating tumor versus the normal post-surgical FDG avid response?
That may be pertinent in some of the cases who had surgery. Often, since we've been giving chemotherapy, most patients have had chemotherapy after surgery, and sometimes it's been delivered when they became symptomatic. So there's been a longer interval. And then we've given radiotherapy after they've progressed on chemotherapy. In all the cases, we've done PET scans to help our planning before the radiotherapy, but there is a variable interval from the time of surgery, and the surgery's been very variable as well. So that could be a factor in some of the patients. But sometimes we've found that the PET activity remains even after radiotherapy, so that may be positive in the post-radiotherapy scan as well, and that will wash out in the analysis.
And then how do you determine in-field failure when it must be very hard to determine that when you start getting this confounding FDG pneumonitis picture?
That's right.
How can you be really accurate about determining an in-field failure?
Not everyone had pneumonitis. Of the 14 patients, 4 had enough that we couldn't evaluate. Because we do PET and CT scans, we were able to go back to the CT scan to see if there were masses of disease or just a diffuse picture that was consistent with pneumonitis. And having an experienced nuclear physician evaluate it was help in deciding what to call it. But some we just couldn't evaluate.
Do you find that the volume of the tumor is a predictor of response to IMRT?
We certainly haven't looked at that. I know that some of the patients who've recurred in field, it's been where they've had rib involvement, T4 disease, and that's not been resected. So that could be a factor. I don't know whether the dose we're using is too high, too low, or just right. We've had a few recent patients who've had such bulky residual disease, and we were treating a larger volume than other patients to a higher dose that we drew back, and instead of giving that volume 60 gray, I've given only 54 gray, because I suppose they're more at risk of metastatic spread, and short-term local control is better than nothing. But we'll follow these patients up and see what happens. I don't think the New York data has gone as high as we have in their series of perirectomy patients having radiotherapy, and they've had more toxicity.
Have you worked out any way for the surgeons to preferentially mark the area of residual disease that helps you with your radiation therapy planning?
I need to treat such a wide area, and I can localise it from the PET scan. If it is active because it's a post-operative change, that's fine, because that's the area I need to include in my volume anyway. So it's not such a consideration. I did try to get to the operation if I can, but that doesn't always happen. And unfortunately, where I work, I can't get the surgeons to come to see my planning technique to just say whether I need to optimise it in any other ways. So we're looking at doing PET scans afterwards to see where the local recurrences are and hope to avoid them by using wider margins if it's safe.
If I'm correct, I think the Sloan Kettering crowd use, did they not use 3D conformal radiation in the paper reported by Gupta?
They've advanced since then. So now they're using IMRT.
Conformal radiation. So that's probably explains the high local recurrence rate that was reported in that series.
That's right, yes. They've published on that as well. Gupta's got a paper in the JTO showing where the local recurrences were with the old technique.
I guess the only other comment I would make would be that 600 patient series from Flores and past, which, you know, on the face of it shows no difference in survival, but you know, one has to remember that there was a statistically higher stage in the patients who had EPP, and furthermore, the analysis of whether or not they got multimodality therapy influencing surgery is sort of a foregone conclusion. One only generally gives adjuvant chemotherapy and adjuvant radiation therapy to patients who survived, not only survived surgery, but actually done well following surgery. So
Sure.
that's it. You know, I don't even want to put that part of that particular analysis in there. It's very biased.
Well, it's been a contentious issue for many years, and I think it will continue going on until there's some randomised trial addressing the issues. But unfortunately, all the surgeons I work with and all the surgeons except one in Australia no longer want to do pneumonectomies. And I think that's the trend in other countries as well. Thank you.